Welcome to this California Primary Care Association's Patient-Centered Health Home Initiative program. This e-learning module is a training tool to support your efforts in the transition to become a patient-centered health home and NCQA certified. This module, After Hours Care 24/7, is an element of care that promotes and expands access by ensuring that established patients have 24/7 continuous access to their care teams via phone, email, or in-person visits. Hi, my name is Patricia Talbot, one of the CPCA's Patient-Centered Health Home Transitional Coaches. I will be your presenter for this After Hours Care 24/7 module. At the conclusion of the webinar, you will be able to gain a thorough understanding of after-hours 24/7 care, recognize NCQA factors for Element 1B after-hours access, identify strategies to meet after-hours 24/7 care requirements, understand the documentation requirements for both the clinical advice and NCQA for after-hours 24/7 care, and finally, acquire knowledge on how to put the principles of after-hours 24/7 care into practice. What this element of care means, it means to promote and expand access by ensuring that established patients have 24/7 continuous access. No access equals no care, where on the other hand, access equals quality and timely care. It's all about accessibility, the ability to receive medical care whenever one needs it. It is the defining element of primary care. As a reminder, patient-centered care is care organized around the patient. It is a model in which health centers or clinics partner with patients and families to identify and satisfy the full range of patient needs and preferences. It is a partnership among practitioners, patients, and their families to ensure that decisions respect patients' wants, needs, and preferences. The patients have the education and the support they need to make decisions and to participate in their own care. So let's look at the next slide. Patients are informed, able to participate in their care and receive care when they want or need it, with consideration to their cultural traditions, their personal preferences and values, their family situations, and their lifestyles. As I said before, it is a partnership where informed, active, participatory patients and families are receiving accessible, well-organized, responsive health care delivery, which correlates to effective care. So let's look at the element of after-hours care. Patients now receive care when they need it. This means a patient can access after-hours services. Providers can obtain personal health information in order to provide appropriate care or advice. Patients receive the support they need and either gets an appointment for follow-up or a clinic staff makes a follow-up communication, such as calls or emails. As I said before, it is a partnership. Patients are then satisfied. This is effective care, improves patients' experiences, and increases efficiency. Let's now look at the triple aim. Improve patient experience of care, improve health outcomes, and reduce the per capita cost of health care. So care, health, and cost. Let's look at the triple aim in regards to after-hours care 24/7. Care, patients receive support when needed. Health, improve outcomes when patients receive direction, improve self-management. Cost, reduces unwarranted ER visits and associated cost. When care is patient-centered, unneeded and unwanted services can be reduced for sure. So let's get to the NCQA elements and factors. Element 1B is where you will find the after-hours care Requirements. It's worth 4 points. NCQA requires that the practice has a written process and defined standards, and demonstrates that monitors performance against the standards for the following 5 factors. Providing access to routine and urgent care appointments outside of regular business hours. Factor 2, providing continuity of medical record information for care and advice when the office is not open. Factor 3, providing timely clinical advice by telephone when the office is not open, and this is a critical factor. Factor 4, providing timely clinical advice using a secure interactive electronic system when the office is not open. And Factor 5, documenting after-hours clinical advice in patient records. Now, how is this scored? As I said before, is worth 4 points. The ultimate is having all 5 factors, giving your health center or clinic a 100% score. The next best are having 4 factors, which must include Factor 3, which is a critical factor that would give 75% score. A good score would be 3 factors that also must include Factor 3, giving a 50% score. Of course, you must meet the critical factor to at least score a minimum score. NCQA explanation for this element, as provided in their standards manual, are patients can access the clinician and care team for routine and urgent care needs by office visit, by telephone, or through secure electronic messaging. Practice staff considers patient care needs and preferences when determining the urgency of the patient results for same-day access. For all factors, the practice must provide their defined standards or policies with a date of implementation and must be in effect at least 3 months before applying for NCQA certification, and demonstrate they have monitored performance against the standards they have defined. So let's go through each factor individually. Factor 1, providing access to routine and urgent care appointments outside regular business hours. The practice offers access to routine and non-routine care beyond regular business hours, that's 9 to 5, such as early mornings, evenings, or weekends. If the practice does not provide care beyond regular office hours, it may arrange for patients to receive care from other non-ER facilities or clinicians. If your health center or clinic is currently open past 5 or on Saturdays, your health center or clinic passes this element. For Factor 1 documentation, show the hours that the health center or clinic is open that includes extended hours is sufficient. A process for arranging after-hours access is not required if the practice has regular extended hours. For those who do not have extended hours, those practices need to have a documented process for staff to follow, either guidelines or policy and procedure, for arranging after-hours access with other practices or clinicians. Whichever way, the practice needs to provide a report showing after-hours availability or materials communicating practice hours, patient handouts, or snapshots of the websites or patient portals if the hours are included. For Factor 2, providing continuity of medical record information for care and advice when the office is not open. Patient health information must be available to on-call staff and external facilities for after-hours care. If care is provided by a facility that is not affiliated with the practice or does not have access to the patient records, the practice is required to make provisions for patients to have an electronic or printed copy of clinical summary of their medical record. That can be by providing a patient with individual care plan, portable personal health records, electronic flash drive, a paper copy of a clinical summary, and preferably after each visit. Telephone consultation with a primary clinician who has access to patient's medical record is acceptable. And of course, for those who have electronic health records, access to those records. Factor 2, documentation. You will need to provide a documented process for staff to follow for making medical records information available for after-hours care, a guideline or policy and procedure that directs the staff. Element 3, providing timely clinical advice by telephone when the office is not open. Patients can seek and receive interactive clinical advice by telephone when the office is closed. And interactive means that questions are answered by an individual and not just a recorded message. Factor 3 is a critical factor and must be met. Because it reduces patients' use of the emergency room and provides more patient-centered care, Factor 3 has been identified as a critical factor and must be met by practices to score higher than 25% on this element. So for Factor 3 documentation, it requires that the practice defines a time frame for a responsive and monitors that timeliness of the response against the practice's standard. So you will need a documented process for the staff to follow for providing timely clinical advice by telephone when the office is closed. Of course, a guideline or policy and procedure that directs the staff. Have a report summarizing its actual response times. The report may be system-generated or collected based on at least 5 days of calls. So Factor 4, providing timely clinical advice using secure interactive electronic system when the office is not open. Patients can seek and receive interactive clinical advice by secure electronic communication when the office is closed. Again, interactive means that questions are answered by the individual. And Factor 4 is not applicable if the practice does not have the capability to communicate electronically with patients. Factor 4 documentation. Factor 4 requires the practice to define the time frame for a response and monitor the timeliness of the response against the practice's standards. You will need a documented process for staff to follow for providing timely clinical advice using a secure interactive electronic system when the office is closed, and have a report summarizing its actual response times. The report may be system-generated or collected based on at least 5 days of electronic messages. Factor 5, documenting after-hours clinical advice in the patient records. After-hours clinical advice must be in the patient record, whether it is provided by telephone or secured electronically. Factor 5, documentation. You will need a documented process for staff to follow for documenting after-hours clinical advice in the patient's record, and I would include the timeliness of getting it into the record, and have at least 3 examples of clinical advice documented in the patient record, or generate a report identifying how often advice is documented in the medical record. So the report must provide the percentage of patients with the clinical advice documented in the medical record of those patients who received after-hours clinical advice within a recent 1-month period. So the denominator would be the number of patients receiving after-hours clinical advice, and the numerator would be the number of patients with after-hours clinical advice documented in the medical record. We will go over options that you may want to consider in meeting the factors 1 through 5 further in this module. Whenever I'm working with one type of certification, I also look at the requirements of another, such as licensing, 330 requirements. So for those who are FQ8C or FQ8C lookalike, the next few slides provide information about HRSA requirements after-hours coverage. HRSA requires health centers provide professional coverage during hours when the center is closed. They will ask, is professional coverage for medical emergencies available to health center patients after the center's regularly scheduled hours through clearly defined arrangements, and that should be in writing. So based on HRSA Site Survey Guide, HRSA will be looking at the following 6 items. What specific mechanism or arrangements does a health center have for after-hours coverage? Do all patients receive a written or verbal explanation regarding the procedures for accessing emergency medical dental care after hours? Does the general phone system provide information on how to access emergency care after hours? Is any written information about accessing care after hours provided in the appropriate languages, literacy levels of the health center's patient population? Is the answering service and/or provider able to communicate in the appropriate languages to serve the population? And finally, does the coverage system have established mechanisms for patients needing care to be seen in an appropriate location and assure timely follow-up by health center clinicians for patients seen after hours? Through the next set of slides on various options, we'll address how to meet both NCQA and HRSA requirements. Here's an interesting survey done in 2009 by the Commonwealth Fund, where they surveyed primary care physicians in 11 developed countries, which showed that there were fewer than 1/3 of American primary care doctors reported they provided after-hours care, the lowest rate of the countries surveyed, and this needs to change. Another analysis of primary care practice that provide after-hours care conducted in June 2012 by the Commonwealth Fund found that success in delivering care at nights and on weekends was closely related to physician buy-in. Effective communication bolstered by electronic health records and committed to improving access and continuity. So how do we get providers enthusiastic about covering after-hours clinic and call? Well, let's start with contracting with 24/7 coverage. Include after-hours call in all providers' contracts and show base pay plus call pay for total exempt salary. This illustrates the value for call and is inclusive of the contract. Consider amending current contracts that do not include after-hours calls. Those providers that receive hourly pay, consider a monthly stipend for taking call in their rotation. Make this an organizational-wide change so to improve patient care and work towards patient-centered health home. It is important that providers have satisfactory balance with call coverage and family life. Most primary physicians expect to have to take call wherever they work. It is the attention to the flexibility and sharing of call that recognizes the balance of physician's life or provider's life and career. Sharing call amongst all practice providers, including nurse practitioners and physician assistants, will keep days, evenings, weekend call duties light and ensuring call schedule flexibility so changes can be made with peers when need arises. As a previous CEO of a health center, what worked for me was that I would meet with all the providers with the goal that all shifts and call would be filled before the meeting could be adjourned. I provide them with a template of the monthly schedule and ask them to fill where they wanted to cover. After a lot of discussion, a monthly template was developed. Yes, there were compromises and exchanges for second choices, but it was wonderful to see them work as a team to meet the needs of our health center. Having a regular schedule provided job satisfaction. They also understood if something came up, they needed temporary change, they could go to a peer and ask for a switch. It is important that all primary care providers share within the call group and as equally as possible. Sometimes you may have a provider that prefers evening and weekends, so other providers may not do as many. But it is important that that person needed to change to a shared rotation, that the other providers would need to fall back on the required equal rotation. As far as extended clinical hours, you may want to consider having all staff required to rotate an evening a week or a weekend every 4 to 6 weeks or whatever works. When everyone is required, then it is just part of the whole organization and easier to adopt. So the various after-hours care options that we are going to discuss are after-hours clinic, answering services, health center group coverage, coverage networks, telephone advice, asynchronous email communication. So which is right for your organization? Let's start with after-hours primary care clinic. The practice offers access to routine and non-routine care beyond regular business hours, such as early mornings, evenings, and weekends. This is factor one. Remember, after-hours clinic is so patients may access both routine and non-routine visits. However, if short-staffed, then after-hours clinic for more urgent care needs is better than referring to another provider to service your health center's extended hours. It provides a continuity of care when using minimum staff. The cost of its operation is reduced compared to routine clinics. Having after-hours primary care clinics increases capacity in your facility. It also increases the revenue. Again, hiring staff to share evening and weekends equally is important. To cover evenings, some health centers have shifts for staff that are 8 to 4 or 9 to 5, with the second shift coming in 1 to 9 or 12 to 8. Consider hours for more urgent needs when staff availability is limited, as I've said before. Another option is using an answering service. A live person is required to speak to patients. Although not as optimal as health center call group, an answering service can filter out the non-clinical calls and forward clinical calls to the provider on call. So the benefits of the answering service would be provides patients with a genuine person on the other end of the line and all the benefits that go hand in hand with the live interaction. Provides interaction with trained operators that show concern, care, and empathy while ensuring professional service and immediate help. And they provide written or electronic feedback of patients called to the office for follow-up and documentation. Usually that is the very next morning. I like using the medical answering services because medical calls will be the only type received. And operators are trained and become experienced in the medical industry. The medical answering services are typically HIPAA certified, while most generic answering services are not. Medical call service agents act as an extension of the health centers and can be utilized during lunch or dinner, the closed hours, as well as after hours. Medical answering services, you can find them bilingual. They do exist and can be searched on the internet. Well, you might consider local services as they understand the physician call groups within their area. Some regional, state, or national services may be better choice based on training response and languages provided. Just remember the health center must have a provider available to take the answering services medical-related calls and patient messages. Medical answering services will provide patient messages either by direct phone call or by sending it to a PDA, a cell phone, or pager as a text message. HIPAA compliance needs to be considered so that messages do not have any patient health information or it is encrypted. I know of a health center that the providers would schedule the patient for their next morning appointment through accessing the electronic health record after hours. This enhanced access and prevented delays and ED visits. I thought it was a great idea. The next various option is health center clinics primary care group coverage. This is an internal physicians or nurse practitioners or PAs in your practice. Who can share the after-hours call group? So if we just are addressing after-hour calls and not hospital call, all health centers, primary care physician, nurse practitioners, or physician assistants may participate. If your health center or clinic provides hospital call coverage, then it may make more sense to rotate just those physicians as they are already committed to call. It is important that all your primary care providers participate in taking after calls in a rotation basis, making it as equitable, as possible. Perhaps each provider takes a 24-hour call during the weekday and rotates a weekend every 4 to 6 weeks, whichever works for the group. As I said before, after-hours calls should be part of the provider contract, which may be part of the exempt salary. For those paid hourly, some health centers have paid 1/4 of the hourly rate while they were on call. So you might want to consider aligning with other health centers in your local or regional area and form an after-hours call group. The advantage is that would be less days in rotation. The disadvantage is more calls to take while on call duty. Or consider as a health center to form an alliance with private practices. At one time, the health center I was involved with rotated our providers with our local primary care providers. This was a collaborative effort. The advantages are the same with the health center network, but also builds local relationships. The disadvantage, again, would be more calls to handle while on call duty. I do want to say here that you should first check with your malpractice insurance carriers to ensure that malpractice covers your health center or clinic providers for after-hours call advice to a non-health center patient. Telephone advice or triage line as another option. Typically, these types of companies use registered nurses for advice and triage. A few use physicians. You could consider establishing a regional telephone advice triage center using registered nurses to triage and send clinical calls to the provider who's on call after hours, perhaps even nurse practitioners or PAs. The advantage is that the health center RNs would be familiar with some of the patients who call or message and familiar with operations and staff of other local health centers. There are a handful of registered nurse triage companies that provide services in the United States. Some tailor their services for managed care health plans. You can query the internet to find these companies and investigate if you are interested. Home devices are increasing with the electronic health record technology, and one may need to consider these devices for surveillance after hours. Just a consideration to think about here. And I just want to mention, if you're looking for triage guidelines, the gold standard used by most health plan call centers is the Smith-Thompson Triage Guidelines. I have included their website for your reference here. So the next option would be asynchronous email communication or patient portals. Asynchronous tools enable communication and collaboration over a period of time through a different time, different place mode. These tools allow people to connect together at each person's own convenience and own schedule. This is emails and message through patient portals, mostly. The devices used are PCs, laptops, cell phones, iPads, whatever devices, multiple devices are used to provide convenience for the provider on call. Receiving and sending patient health information, emails, and messages should be done within a secure web-based program or patient portal, so there is no retention of patient health information on traveling devices outside the health center or clinic. And consider space and place. Providers must maintain confidentiality when receiving and sending patient health information, which requires space and place to make it happen. This means no family members, friends, etc., within the confidential space and place. And consider out and about. Providers need to be cautious of surroundings when out and about when receiving patient health information, so to protect it. I think it's prudent here to mention the HIPAA compliance on messaging. Make sure that electronic messages do not include patient health information or are encrypted. As of February 2010, the HIPAA rules are enhanced by the American Recovery and Investment Act. The high-tech section of this act implements significant penalties for breaches of HIPAA. And you can reference that by going to HIPAA 2010 High-Tech Impact on Emails and Web. Really, text messaging is not recommended under any circumstances, but a few random studies indicate providers text regardlessly. Standard text messages are not HIPAA compliant. The provider and clinic would be subject to hefty fines for HIPAA violations. Standard messaging is stored forever on the server of one cell phone service provider. That's scary. There are secure text messaging platforms available. Even if you use encrypted text messages, should not be decrypted and stored on the cellular provider system in ways that can be accessed to unauthorized personnel. It is highly recommended that electronic messages is covered within your HIPAA security policy. Google HIPAA compliance text messaging apps, which you will find a variety of apps available. So HIPAA compliance for emails. Standard emails are not HIPAA compliant. Encryption with password protection is required for emails pertaining patient health information. It is highly recommended that email is covered within your HIPAA security policy. Work with your HIT department to ensure that patient health information remains secure, and then train all staff on the policy and how to encrypt patient health information emails. Most EHRs now have secure application for after hours, off-site access to patients' health information. So you'll find those such as eClinical Mobile, NextGen Mobile, Ocean's, Epic Care Everywhere, and even Athena has a current beta mobile product. For those who do not have electronic health records or unable to access patient health information, will have more of a lengthy process to meet this requirement. Provide patients with a summary or a care plan upon leaving the office. So alternatives, access, have the provider access patient medical records after hours by providing them keys to the facility and records room, and be able to deactivate and activate the alarms. So clinical advice documentation. If using paper, create your own form, which should minimally have the following information: patient name, patient date of birth, person calling if other than the patient, date and time of call, reason for call, information given by patient, clinical advice provided, required follow-up, and idea of responding provider. Ensure provider brings in the documentation to be filed into the patient's medical record. For electronic health records, have a place for encounters that can be used as documentation of after-hours communication and care and can be trackable. Communication with clients about after-hours coverage. For the new patient, every new patient will want to know how to access services and how to reach their provider after hours. New patient orientation should include written or verbal information about how to access after-hours care and what to expect. The best practices is to give these directions to patients after each health center or clinic visit. Patients expect to be able to access after-hours services and receive the support they need. It is important to have open communication that facilitates mutual trust, respect, and commitment while enhancing the patient's well-being. The patients will be more empowered to manage their care, follow care advice, and be satisfied customers. I wanted to say just a bit about enhanced revenue. By having after-hour clinics, you can enhance reimbursement for the face-to-face visit with the additional Medi-Cal, Medicare reimbursable visits. Some Medi-Cal managed care and HMOs or IPAs will pay bonuses based on decreased emergency room visits. Some are paying bonuses for after-hours care documentation, such as Partnership Health Plan of California. For tracking after-hours communication, internal codes can be used. Use an internal code to document after-hour communications, and use an internal code to document electronic messaging documentation during and after hours when corresponding with patients through secure electronic communication devices. One can use appropriate CPT codes for tracking as well, and some third-party payers do pay for those codes. Not many, but some do. Now let's put the principles into practice. The transformation. Buy-in. From leadership, meaning board, administration, to providers, to all staff. The transformation needs to be organizational-wide. Timeline. It should be your best guess estimate while considering other competing projects. Be true to yourself and staff and come up with a timeline that best fits your organization. Developing a plan. Transparency through the planning process enhances buy-in. Include the aim statement and objectives with tasks. Try to keep on timeline and delegate the tasks to those who most likely will be able to complete within the stated time frames. And working with providers, provide overview and why necessary for call coverage. Bring in 3 months of blank calendars, pencil in. And when there are holes and aren't covered days, then you can see them and why some changes and compromise needs to happen. Providers working together show flexibility and responsibility to change. Training the staff. Remember, all staff need the communication on how after-hours care works and how to communicate information to patients. Training will be needed for scheduling of providers and dealing with providers' requests, and also informing the answering service and the local emergency departments. A little behind, sorry. So orientation of patients. Develop written instructions for new patients. Include instructions on websites and patient portals. Assign staff to provide verbal instructions. such as the providers and medical assistants and nurses. I feel this is important after the visit before they leave. And provide a plan for continuous effort and consider providing patients information how to access after hours after every visit. And after hours telephone messaging, consider a script and after hours message for the general phone line. If using an answering service, script an after hours message for their staff to use. And always include, if this is an emergency, call 911 or go to your local emergency room. Your policy should define the time frame for a response, either by call or secure interactive electronic system, and monitors the timeliness of the response against the standard practices. The report may be system generated or collected based on at least 5 days of electronic messages. Now, I would say that one should designate a person to make random calls to check that the after-hours system is working within the standards set forth, such as checking on the phone messaging, checking on timely pickup, and the response time. So John Hickner says similarly the same thing. After-hours call systems should be monitored periodically to ensure the systems are safe, effective, efficient, equitable, timely, and patient-centered. Patient complaints about suboptimal after-hours care should be investigated promptly. Continuous quality improvement principles should be applied to access and improve after-hours care systems, such as we use them to improve office care. So as far as meaningful use, there is no direct corresponding or crosswalk for meaningful use care goal to the patient-centered health home element B1, after-hours care 24/7. The meaningful use overlap is really more general to the care goal A, improving quality, safety, and efficiency, and reduce health disparities, and meaningful use care goal B, engaging patients and families. So let's wrap up. Promote and expand access by ensuring that established patients have 24/7 continuous access to their care teams via phone, email, or in-person visits. The patient has a documented process for arranging after-hours access and provides a report showing after-hours availability or materials communicating practice hours. Patient clinical information is available to on-call staff and external facilities. The practice has a documented process for making medical record information available for after-hours care. The practice has a documented process for providing timely clinical advice by telephone and has a report summarizing its actual response times. The practice has a documented process for staff to follow for providing timely clinical advice using a secure interactive electronic system and has a report summarizing its actual response times. After-hours clinical advice must be in the patient record. The availability to download is a checklist for all the documents that are required for Element 1B and a few examples. I hope this helps. Well, it was a pleasure to present to you today. Hope this was useful information. If you have any questions, you may email me. I wish you the best.